So I want to thank you for your patience. I know that as all of you know, and by the way, I'm using this recording for all three of my mental health classes that I am currently instructing right now, which is, I think, pretty cool because one is for a VN class, one is for an RN ADN class, and one is for an RN BSN class. So I think that it's important to go over all of it. However, what I test you on will be, of course, a little bit different. Um, there's a lot of information, obviously, when it comes to this. And I know I'm late for my ADNs, especially in watching this video. I was hoping that you could have time to watch it before you come to class. If you do have time, great. It is going to be a tiny bit longer than I thought, but I really want to try to keep it to 45 minutes. And the reason being is because, number one, as you know, my laptop was forcefully taken from me, so it's fixed, which is great. Um, but also because this is not the complete lecture. It's something that I will post. You can go back to and look at. You all know that I make study guides. I don't think you need to know every single ounce of information on this. As we've spoken many times before, we are generalist. We are not specializing in this. And these medications, just as many medications, are very confusing. And for most of you, you have not probably been introduced to what these medications even are. So I want to not confuse you. I want to make it very clean, and then of course we'll have the lecture again in class in a little bit more depth and have you to have your questions and then refer back to the video. So let's get started. Let's take a look at the time. We are at 9:13 a.m. It is Sunday morning. My apologies. I was going to post this yesterday, but after trying to catch up on grades, I just couldn't. And I wanted to make sure that I gave this a lot of thought. And I think that you would appreciate that in the end. Okay. So very important for me at the top. So medications can be a part of the recovery process, meaning that I think you all are aware of this. It's not a necessity. It is a part. And just like with any sort of treatment, for mental health, this is something that is offered, I could give many examples, and I'm going to really try not to do that here. I just more want to give the factual so that you can get a nice little foundation down so that when we come into class, if you had time to watch it, great. But I'm so sorry for my RNs tomorrow at Mission. So so medication can be a part of it. It's called MAT. We call it MAT treatment, which is medication assisted treatment. And some of them are considered to be abstinence-based. When I say abstinence-based, it means that it does not have anything to do with the reward pathway, meaning it does not ignite dopamine in the reward pathway. For those of you who we have not started this yet, which are my VNs, you have done some work on it. We start our lecture on this tomorrow. That may not make as clear sense what that means, but it will tomorrow. And it's medication-assisted treatment also for harm reduction, which means that we are trying to reduce harm. There are different types of sobriety. I would, and please also, with my disclosure, what I say and how I say it and my feelings, this is coming from me. And I always say, take what you want, leave what you don't. If it's evidence-based, I'll say it's evidence-based. But a lot of this, like what I'm saying right now, is coming from myself. And we don't, of course, have to agree on everything and what we believe is right and what we believe is wrong. Me personally, I believe I'm going to meet that patient where they're at. If they're coming to me or to a facility that I work at and they're just not quite ready and they want to continue to use something that's igniting dopamine, that's harm reduction, because you're still using something, and this will make more sense as we go down, that is igniting dopamine. I don't judge that. I commend them for coming in, and who knows, maybe that's the door to open to go to abstinence. Not saying that that's better or worse or what not. I'm just not here to judge. I'm here to help. Okay. So what we really or what I really want to concentrate on is explaining just briefly what a controlled substance means. I think most of you know what that means, but just briefly to give a little bit more, hopefully make this a little bit more substantial. So if you don't know what it means, I think that will help with the connection, as well as the medications that we're going to talk about. I call them anti-craving, but they're not all just anti-craving. Some are used for withdrawal, then anti-craving, then maintenance, and they actually stay on the medication. They don't get off the medication for a little bit. They may stay on it forever. And then some are even used for pain. So I will go through that and what they are used for. I do not expect you to memorize all of this. I would never do that. And I will put on the study guide what I would like you to know, based upon, of course, our board exam. And then also, hopefully, some of these will kind of stick in your mind and they will look familiar to you if you see them in your career. So moving along here to our next question has to do, or our next subject topic here is, what does it mean when, what does it mean to be a scheduled medication or a controlled substance? So that would mean that it does have the potential to be addictive, meaning that it does have, it can go to the reward pathway, release dopamine, and it can potentially be addictive. That would mean something like Percocet. Let's say you broke your leg and you were given Percocet. That's a controlled substance. They line them out 1 through 5. Schedule 1 is not actually used for medical purposes in the United States. That would be like LSD, heroin. Those are not prescribed in the United States. So Schedule 1, not prescribed in the United States. And then as it goes down, and I will explain this better in class tomorrow, I think it's better, or when I see you guys, written out. And then it goes down 2, 3, 4, and 5. And as it goes down, it seems like it should go the other way to me, but this is just how it goes. So number 1 is the most. Number 2 is supposed to, and these are all prescription medications, by the way. Controlled substances cannot be bought over the counter in this country, where we are. There are other places that they can be, but we're talking about here specifically. Schedule 2 would be, if you looked it up, technically still potentially highly addictive, but less addictive than Schedule 1. And that would be an example of Adderall. And I'm not saying that Adderall is a bad medication. I'm saying potential to be, based upon the amount of dopamine that can be released if it is taken in a certain manner. And then we go to Schedule 3, which is supposed to be less potentially addictive than Schedule 2. And then we go to Schedule 4, which is probably something that hits a nerve with me every time I talk about it. You will see it when I lecture. And an example of that would be like Ativan, Ambien, and I mean, benzodiazepines in general. I mean, it's a huge epidemic and in, I mean, many places, but just right here where we live, huge, 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 huge. Not saying they're bad, not saying it's a bad medication, but I do believe that it is overused. I do believe that it is overused in a way of prescribing and how much is being given and how easily accessible that it can be. That is my personal opinion. But I also think that it can be a medication that can be very, very useful. But keep in mind, if you are running in an abstinence-based program, you're in recovery from, let's just say, heroin use disorder. If you're in an abstinence-based program, you would not use Ativan because you are not using anything that is going to ignite the dopamine reward pathway. Of course, and I can imagine some of you are thinking, well, don't you eat, have sex, do these other things that can cause, of course, I'm talking about medication, things that, you would not go to the doctor and be prescribed this medication if you're on an abstinence-based program. Okay, so moving along here, and then we move down to Schedule 5, which is on the scheduled controlled substances, is supposed to be the least addictive. And one of the examples is Nuvigil, which is a medication for narcolepsy. So and what's the pregabalin? Lyrica. Lyrica is also a Schedule 5. I'm trying to think of medications that you guys know. Now, the reason I always tell my patients this, this does not apply. And I always say us. I never say you guys, them. This is just my personal thing. I say this does not apply, or I say this does not apply to those who have a reward pathway, who has been damaged at one point. It may be recovered and things are working in a much better way, in the way that it, I don't like to say should, and I'm doing my air quotes, but this would not apply to that population because their dopamine receptors in the reward pathway, they do not work the same way, which means that if I go online, let's say I went to see my doctor and I did not mention, and that is one thing we try to teach our patients to let them know I'm in recovery. Can you please, and if you're in abstinence base, please don't prescribe me anything that's potentially habit forming or a controlled substance. But let's say the physician wasn't really clear, didn't understand, and they gave you Ativan and you felt so excited because you did what you were supposed to do and you're having really bad anxiety, and the doctor did what they felt was necessary, and that is for anxiety. But then you go home and you read, and it says something to the, and you can look it up, something to the factor of, it's not highly depending on where you're reading, but it's not highly addictive as far as like basically the scheduled substances. So we have to kind of look at that as a block, like to the side, that schedule 1 through 5, that's on its own spectrum. So what I tell my patients if I'm running group is this does not apply to us. It does not apply to recovery, because this is different. Does everyone and I ask them, do you guys understand why? Because of our reward pathways being different, and it's been rewired, and it can be triggered, and it may be, healing and all of this, but it's not going to be the same, basically. And I think that is something that's important to understand. If that doesn't make sense, I think I can make more sense of it. And I don't want to spend too much time on that. I want to spend time on the medication. Okay, so what does it mean to be scheduled medication? We just went over that. So how long does it take to be on the medication? I get this question all the time, and I'm just going to say blatantly, it just depends. It depends. Depends how you're doing on it. It depends how long you want to be on it. It depends on what your goals are. That's really the truth. Most of my patients tend to be on, and it depends on the medication. I'm going to go down, as I'm going down, explain if the medication, what it's used for. Is it used for withdrawal? Is it also used for this? What is it used for, and how long do maybe patients normally, again, normal, air quoting, might be on them, or give some idea. Okay, so we're gonna start here. So I really want to make a point of one of the reasons I think medications can be helpful is that it buys us time. And for those of you who have watched the Ruth Pote video, I did not have my VNs watch it. But for the other 2 programs, it buys us time for brain healing. The longer our brain has to heal, the more efficacy and chance that we may, depending on environment, a bunch of different things, to relapse, right? So this is one thing where medication can be very, very, very helpful. But again, you do not need medication. It can be a part of your treatment. And on the flip side, we just don't, the efficacy of just using just medication, which really shouldn't be happening. But if a physician or you got off the street, however it happened, and you're using it, it's supposed to be used with support, such as therapy, some sort of program, something. Not just taking the medication and letting it do what it needs to do, but also healing a lot of trauma and things that have happened while you've been using too. All right. So starting with Antabuse, I think probably one of the most well-known. We talked a little bit about this, I believe, in most of these classes. So Antabuse is considered an anti-craving medication for alcohol. That is true. So specifically, this is for an abstinence-based, drug, meaning we don't want you to be drinking alcohol because it's aversion therapy. It does not work on the brain. And this is one of, I think, the only one actually, I don't want to speak too far ahead, but yeah, I think this is actually the only one that does not work on the brain. It works on the liver. It works by blocking the enzymes in your liver so that you are not able to metabolize alcohol. Therefore, if you're not able to metabolize alcohol, in essence, you are giving yourself alcohol poisoning, and you will get sick and vomit and not feel good. And it's awful. It can be from mild to severe, depending on how much was drank. And remember, alcohol is, in everywhere, like right now with COVID, we're using hand sanitizer all the time. You may have a little bit of a reaction in that moment if you used anything with alcohol in it or smelt perfume. You might get a small like flushing or kind of like not feeling well. And, but yes, so basically Antabuse, it's aversion therapy. It's considered anti-craving, only used for alcohol, and it does not work on the brain. It works on the liver by blocking the metabolism. If you drink when you're on it, you're going to get sick. One great thing about this medication, it stays in your body for 1 to 2 weeks, meaning that you can't plan, it helps you plan for the bad days. You can't just stop the medication because it's still going to be in your body. So for example, that might be something I would put on your study guide about Antabuse, because I think that's important to know. So, but I would put, make sure that you understand how Antabuse works and whatnot, which I also think is important. The next one I think is under talked about. It's called Camprol. I'm not going to give you both names, but this one I will. So Antabuse is I can't say it. That's why I use the names I use, because you guys know I have a little bit of trouble saying some of these names. Difulcerum. And I'm sure I said that wrong with Antabuse, but that's the other name. Camprol is acamprosate. And this one, we're not exactly sure how it works. So what we think it's doing, it's basically helping to heal the brain quicker. Like Antabuse, this is used for abstinence-based and when I say abstinence-based, I mean a couple different things. Number one, Antabuse does not it does not ignite dopamine in the reward pathway, meaning it's not harm reduction. Camprol, same thing. It does not ignite dopamine in the reward pathway, meaning it is not harm reduction. Camprol is seen to work on the GABA receptors. When alcohol is taken in, it goes to about 5 different places in the brain. The two that I'm going to focus on is your GABA receptor and your opiate receptor. I think many people do not realize that it does go to your opiate receptor, and that is really why it's addictive. Has the potential to be addictive. If it did not go to the opiate receptor, I call it taking the bus. So some things take the bus to get to the opiate receptor some things take the bus in order to get to the reward pathway to allow dopamine to come out, and some go straight to it. And I will mention that as I go along. And I can just tell you right now, the only one I think that doesn't take the bus is, methamphetamines. Stimulants. So stimulants go straight to the reward pathway. They do not take a bus. All the other ones take a bus. And I will say that for every single time so that it kind of starts sticking in our brains. So Camprol is seen to help heal the brain quicker. That is how we think it works. And one of the good things about it is that in my experience, many people I've never had anybody have a side effect to it. People tend to do very well on it as far as not feeling sick. They tolerate it well. Insurance covers it. It's great. However, you have to take this medication multiple times a day in order for it to be effective, because your liver breaks down so much of it. So you have to take the medication 3 times a day. So you have to take 2 pills 3 times a day. Each pill is 333 milligrams. And if my personal guess on why they did this is marketing, because that would equal 666 milligrams, which we all know what that means. That's a unfortunate racial slur. So that's why I think that marketing was smart on that. And so basically you have to take 2 pills 3 times a day. For most of us, that would be hard. Now imagine being newly in recovery and your memory's not doing well. You have a lot going on. So we have to look at the whole patient, as we always do. Would this maybe be a good medication for somebody that's super forgetful, maybe lives alone, is not taking the medication? Because again, if they do not take it 3 times a day, you're not going to reach the therapeutic effect and it's not going to be working. Therefore, you're taking it for no reason. I also want to mention in this moment that medications can be taken together. So I can give Antabuse and Camprol together because I can look at this and be like, well, Antabuse is great. This is going to have an aversion therapy, deter you from wanting to drink, while Camprol is helping your brain heal faster. And the faster your brain heals, the efficacy shows you're less likely to relapse. Doesn't mean you can't, but less likely. And I would say for Antabuse and Camprol, and naltrexone, really, 6 to 12 months are usually kind of like what most physicians say. I say individual, period. That's why I don't even like to give timeframes. But from where I have worked, it's usually like either like 3 to 6 months or 6 to 12 months. But you do not have to remember that. I'm not going to ask you that. I would never ask you that. So yes, so that's Camprol. Not considered to be addictive, and it helps basically to help the brain heal quicker, therefore helping with cravings, and must be taken 3 times a day in order to be effective. I'm going to hold off on naltrexone and Vivitrol because that also works with something to do with opiates, and I want to talk about those at the same time. Something that I do want to mention is just real quick. So Antabuse and Camprol are not used for withdrawal. They have nothing to do with withdrawal. They are specifically for cravings or aversion therapy, which it's under cravings. Now, when somebody is starting to come off of alcohol, as well as benzodiazepines, we have to be very, very careful. And by the way, benzodiazepines, they don't have an anti-craving for that either. So I guess technically benzodiazepines and stimulants and marijuana, they do not have specific medications to help as far as anti-craving, but that does not mean that just because benzodiazepines, stimulants, and marijuana don't have something specific that we can't give them something if they're struggling that can actually help them not use. And what I mean by that, and I'm kind of skipping a little bit ahead, if I had a patient that is extremely anxious and they use methamphetamines, marijuana, cocaine, benzodiazepines, probably benzodiazepines, definitely they're going to be feeling anxious if they're not on that anymore. We have other medications that we can give, such as gabapentin, hydroxyzine, propranolol. We've talked about them. Even though that's not an anti-craving medication, don't you think that could help with anti-craving, even though it's not specifically for it? Because it can help take away that pain that they're feeling. Because I'm sorry, if I'm super, super, super anxious and I had been abusing benzodiazepines, I'm sorry, my brain's going to be on benzos all day because I don't want to feel this way. And I know if I take that pill, I'm not going to feel this way. So I think that's important to kind of look at as a bigger picture. Again, I'm not going to ask you this. This will not be on the board exam, but benzodiazepines, stimulants, and marijuana do not have a specific FDA-approved medication for anti-craving, but that does not mean, because I'll have patients very discouraged, like, this isn't fair, this is, this, that, and the other. And I validate that. And I say, but we can still help with other feelings that you're feeling by either, and that it doesn't even have to be medications. It can be cognitive behavioral therapy, DBT, talk therapy, all sorts of things, meditation, or it could be medication, but not specifically for cravings. So now, nice, we covered that, so we can put that all to the side. Now, benzodiazepines and alcohol. This is something I would probably say is the most dangerous detox because we are afraid of seizures. We do not want these individuals to have seizures. With alcohol, we've talked about this before, but we have 2 different types of medications that are usually given. And one of them would be a benzodiazepine. There are 3 of them that I see given that I think would be the most helpful to teach you. That's Ativan, also called diazepam, Valium, also called diazepam, and Librium. Can never remember the other name. So that's Ativan, Valium, and Librium. And we've talked about this in class. Ativan has a shorter half-life. So if I have somebody that really is not doing good with their liver, is really holding on to things, that might be the one I want to give them because it's a shorter acting. Valium is longer acting, just like Librium. And I personally, in my personal opinion, this is my personal opinion, I tend to like to hint to prescribe those because it's a little bit less bouncing around because it doesn't have quite as short of a half-life, but that's here nor there. I just wanted to make that statement. So that's going on one side. Then we can go on the other side and we can use phenobarbital. Phenobarbital also, by the way, is a Schedule 4, just like benzodiazepines. It can potentially be habit forming. I call it kind of like the old school benzo. It's what people used to take, and you can definitely abuse it because I just said it's a Schedule 4, so it has the potential to be addictive. So it does release dopamine in the reward pathway. And the efficacy between benzodiazepines and phenobarbital being used to avoid seizures, either for benzodiazepines or alcohol use disorder, is the same. It's more based off the prescriber and the patient. I asked the patient, have you gone through withdrawal before? What tends to work best for you? I think that personally is just best. I mean, most prefer benzos, but actually, one of my latest patients preferred phenobarbital. Okay, no problem. And did it work well for you? Okay, not a problem. And if it does work well and things are going okay, then I have no problem with that. Benzodiazepines, sometimes, just as a side note, they'll just use the benzos and they'll wean them off the benzos. Some will take away the benzos and they'll give them phenobarbital. Basically, again, we're trying to avoid seizures. And we already know that benzos can do that. That's why we give them to people who are coming off of alcohol, because I've mentioned before, and we never say this to a physician or NP or PA, benzodiazepines are basically the pill form of alcohol. So you're slowly weaning them off in order to get off of alcohol and benzodiazepines. All right, now moving along to opiates. So clonidine is considered abstinence-based. Clonidine is an old school blood pressure medication. I've not seen it used really for blood pressure in a very few times. But it can help with withdrawal from opiates. Personally, and I'm just speaking from experience, it's not always the most effective. It can work better for some than others. It does not ignite dopamine in the reward pathway. So this is usually for patients who really don't want to go down that, what would you want to call it? I would say like the methadone or Suboxone route. Naltrexone and Vivitrol, which you also will notice are up here, these seem to be now becoming the most popular. I will say that. And that's why we're going to talk them together, because they work for alcohol and opiates, and we'll talk about those. So just finishing up real quick on clonidine, it can be given, it helps to, with, when someone is going through opiate withdrawal, it tends to be a lot of muscle aches and central nervous system discomfort and just very fidgety, and it can help to lower that a little bit. And I'm very honest with my patients, and I will tell them, like, I'm not saying it's not going to be effective, because I don't want to set their brain up for failure. Like, hey, this isn't going to work. Just looking at the time, perfect. But I do let them know, please communicate with me. And if you want to go down a different avenue in your withdrawal period, let me know. Clonidine is not long-term. Clonidine is used just for the withdrawal period. So it's not used for maintenance and is abstinence-based. Again, we're going to skip naltrexone and Vivitrol, and then after I'm done talking about Suboxone, then we'll go back and tag team that with alcohol. So methadone, we've talked a little bit here and there about that. So methadone is harm reduction. Methadone technically can be used for, it's an opiate, it's a Schedule 2, and we know that Schedule 2 can be potentially highly addictive. It's a controlled substance, and you cannot get it over the counter, because we know controlled substances you cannot get over the counter. It must be prescribed by one of us, physician, whatever, PA, all of it, somebody with a license. And it is considered harm reduction because it is an opiate in itself. So a couple different things. Technically, methadone can be used to help with withdrawal from the opiate. It can be used for maintenance to help you not crave the opiate. Again, giving your brain a little bit more time. Also being able to, yes, and I know that sounds funny. Well, you're still using it, but you're using substantially less. And think about it. If you're using heroin, heroin has a very short half-life. You have to shoot up about every 2 to 4 hours. it's very hard to live a, again, quote unquote, normal life and do that. The other thing methadone can be used for is pain. So those are 3 things. Now, just for fun, and I would never test you on this or what I just asked. I just want you to have the whole story, and then, because some people are very interested in this, so I like to give the whole picture, and then I will, of course, narrow it down when we come down to taking our quiz, which is actually going to be on substance use disorder, and you'll see some of these questions also on your final. Now, methadone, in my personal opinion, is not effective for withdrawal. It just isn't. That's my personal opinion. The reason we use methadone is because it has such a long half-life. Many of us have heard methadone clinics. You go to the clinic, you have to go every day, you take your dose. It takes sometimes up to 3 months to be put on the proper dose in order for you not. So the hope is that we get you on the perfect dose. You're not in withdrawal, but you're not nodding off and high. That is not easy to do. And a lot of this is subjective. So it's coming from a person, as we've talked about with the frontal lobe, critical thinking, judgment, and impulsivity, maybe not thinking properly or in their own proper way of how they would normally think. It's a very difficult thing to do. It can be done. I've seen it done. I've seen huge success stories, just like I've seen huge failures, and people, I've seen them abuse the system, just like anything. But I've also seen people do so well. Some people will be on methadone for the rest of their lives. In my personal opinion, again, I just feel like they're in more pain if you're taking them off, like, let's say heroin, and then you put them on methadone and then you take them off methadone. I see them withdrawing twice, and it's like twice as horrific. Personally, that's my opinion, but it can be used for withdrawal. I personally do not think we should be using it for pain management. I think it's very highly addictive and it's dangerous. Think about respiratory depression. I'm not saying if you've been on methadone, that's bad. I just personally think there's other things that can be used. I personally think that it being used as a harm reduction method is good if done in the correct way. And what I consider the correct way is you go to the methadone clinic. The methadone clinic doesn't just say, yay, okay, we got you titrated, we did this, we did that, all's good. No, there are appointments, you are drug tested, you see a counselor. There's accountability held. It's not a perfect system, and I'm not trying to sell that to you at all. I just like the facts to be shared. And methadone, whether you find this important or not, I do want to mention a lot of patients that do take methadone, and I think this is maybe one of the reasons why, no, there's probably many more reasons, but a lot of it is ran through where I kind of compare it to abortion, and that's why we say we will not have this conversation, because we all have our own opinion. And like who pays for what and whatnot. And sometimes we do end up paying if we don't have like a lot of our patients, I work in a methadone clinic on call, don't have insurance. Who's paying for that? Basically, I'm not trying to become political, but I'll tell you right now, I'd rather pay for that than have more homelessness, have more, in the big picture. In my personal opinion, I've seen it with my own eyes, and that's all I'm going to say about that. And I wasn't even going to bring that up, so I apologize. I just kind of want to have you think of it yourself and kind of make your own belief in that, because you will see patients come in who are on methadone and they might be in withdrawal and come in your ER and be like, oh my God, I missed the clinic today, I'm going into withdrawal, can you help me? And there can be a lot of judgment and stigma on that. But again, and I remember someone asked me, why don't I use Vicodin or something? And well, yeah, Vicodin has a much shorter half-life. You can actually miss a day of methadone usually. And yeah, you don't feel really great the next day, but it gets you to the next day. And then as you start to build rapport, and you're not coming up positive for other things, and you're doing really well, you actually get what's called steps, and then you get to take it home. And that's another reason we drug test you, because we want to make sure that it's in your body and you're not selling it. So I think I said enough about methadone. So methadone is harm reduction. Some people don't like when people say this. I don't even really like it, but I think it's the easiest way to explain it. It is kind of really replacing one thing for another. However, it is meant to cause good and hit that sweet spot, if you will, if used properly. Okay. The next one is Suboxone. So Suboxone, I'm sure at least 10 of you listening to this right now have heard of it. So Suboxone is interesting. It has an active ingredient called buprenorphine in it. And buprenorphine is an agonist. It's kind of a partial. It partially stimulates the opiate receptor. So I consider it harm reduction because it partially will ignite the opiate receptor. And I will explain this. So you do get partial dopamine feeling. However, it has a ceiling effect of 32 milligrams. And maybe the first couple days you feel high, but you don't get a high off of it. But from what I've heard from my patients, the efficacy, the fact that insurance is now willing to pay for it, it was hundreds and hundreds. I mean, oh my God, I fought on the phone with insurance for so long when I first started really more understanding Suboxone about 10 years ago. And now it's like no problem because they see the efficacy. Hey, they're on this medication. They're not in the ER all the time. We're going to rehab, every 6 months, right? Not saying that if that happens, that, do what you got to do, right? But so Suboxone, yes, there is Subutex. We're not going to talk about that. The only difference, it doesn't have naloxone in it, which means you can get high off of it. So, and I'll explain right now why. So buprenorphine is the active ingredient. So that is what's going in and going up to your opiate receptors. And I call it kind of playing with them. So it's not fully covering it, but it is activating enough to get a little bit of dopamine, and it kind of just helps the overall mood as well. And it does help the brain heal. And then you have naloxone. They add naloxone in it as well because so we know that we have Narcan, and that's what we give if somebody has overdosed on opiates. Naloxone, which would be considered the middle of a Narcan, is a very short half-life, right? It's like minutes. Then naloxone, which is the middle, and then naltrexone right here. Essentially, they're all the same things. They just have different half-lives going in that order: Narcan, naloxone, and naltrexone. So they put naloxone in Suboxone, and Suboxone needs to be placed under the tongue and your vascular system underneath your tongue. That is how it is absorbed. If you swallow Suboxone, it does not work. Your liver does not know what to do with it, and it's a wash. Many people ask me, well, I don't understand. You're giving buprenorphine and naloxone. You just told me that Subutex you can get high off of, but we're putting, or actually, I didn't even need to say all that. You're putting naloxone, which is something that reverses and it'll pull off. So basically, buprenorphine goes in. It has a very high affinity for the opiate receptor. I forgot to say that about methadone, that too. So methadone and Suboxone, you actually have to be in moderate withdrawal to even start. If you take this and you are high on opiates, you will go into full-blown withdrawal, and I'm sorry, you're screwed. You got to wait it out. It's awful. I'm so grateful this has never happened to me. I do my very, very best to make sure. I use the COWS scale. We probably talked about that. And if not, it's on your resources when you do clinical with me and we talk about it. But buprenorphine and methadone have the highest affinity for the receptor or over the other opiates, such as heroin, Vicodin, Percocet, all of that. So we wait until they're in partial withdrawal, which sucks, but oh God, it's just the look on someone's face when they take this medication and it is working. And it usually takes, I would say, about 2 days to reach full effect, but just even that first, it's just beautiful to me, to not see them suffering. Now, the reason why you do not get thrown into withdrawal taking naloxone, because we know naloxone is going to potentially, just like Narcan, sorry about that. Just one moment. Madison, my apologies. And we're almost done. We're going to wrap up because we can talk about the smoking ones in class. Hey, come here. So what I wanted to share here before we talk about the last one is that the reason why you're not thrown into withdrawal, and I'm going to keep this simple, because there's so many medications, and I'm sure you're all like rubbing your eyes like, oh my God, this is insane. Is because the buprenorphine has the bioavailability to go under the tongue. Naloxone does not. So it is not absorbed. You actually do swallow it. Then I get asked, well, then why is it even put in there? I'll tell you exactly why. So the reason that someone would get sick, most people think, let's say you took Suboxone and you're like, oh my God, you threw me into withdrawal, because no, you got thrown into withdrawal because the buprenorphine had the higher affinity and you were not in enough withdrawal in order to take the medication yet. It had nothing to do with the naloxone. The reason the naloxone is in there is if you decide to crush up your, burn down your, it's a film that goes under the tongue, or the tablet if it's Subutex. But again, we're not talking about Subutex because that doesn't have a naloxone in it. We're talking about Suboxone, which is why we use it, is because it has a naloxone in it and you can't abuse it. So you burn it down, and if you inject it or snort it, it does have the bioavailability. So what is it going to do? That naloxone is going to throw you into full withdrawal. So it helps to, just like antabuse, hinder that individual from wanting to abuse the Suboxone. And I'm just going to be real honest and say this out loud. I tell my patients, why even waste? Why do that? Why waste your money? Suboxone is way more expensive than heroin. If you're going to use. And I say it as a joke to, my population, because they get it, and they laugh, and it's like, yeah, I mean, you're right. And of course I say, I'm not, of course, saying I hope you do that, but I mean, anyway, it's kind of we all have our jokes at our work, right? I think all of us, depending on where we work. So I hope that made sense. I will explain that more in class of why naloxone doesn't make you sick when you take it, but if you abuse it and inject it, it has to do with the bioavailability of taking it. And remember, methadone and Suboxone have a higher affinity for the opiate receptor, meaning it will throw off any other opiate that's on it and throw you into withdrawal. Now, we already talked about this. Unfortunately, stimulants, marijuana, and benzos do not have anti-craving medication. We'll talk about smoking tomorrow. And in fact, I think tomorrow, I'm going to stop now. And tomorrow we're going to cover naltrexone and Vivitrol for opiates and for alcohol, only because I'm hoping that enough of you watch this. And then I will make another video, part 2, because I want it to be posted, of the smoking part and the naloxone and Vivitrol. But I don't want to overdo it. Okay, so I hope that was all good. That will hopefully set you up for a much better lecture. For my VNs, you're not getting this part tomorrow. You're getting the basis because you didn't get that yet. You'll get this the week after. So by then, both videos will be put up. For my BSN students, you'll get this part. Hopefully, you'll have time to watch it by Tuesday when we have class. And then for my ADNs, if you have time, please, 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 I'm hoping that you watch this. And then I will post the second video about Vivitrol, naltrexone, and smoking, so that you have it for your recall. All right. I appreciate you guys so much for your patience, for just being you, and everything. So have a great day, and I will get this downloaded and uploaded. Thank you so much.